Today's mission, we are going to absolutely master the high-yield framework for malabsorption syndromes. Let's do this.
All right, listen up. Think of malabsorption as a complete factory failure. The intestinal villi, they're under siege. I want you to picture them like a lush green field just getting mowed down, totally flattened. That's the core problem, a complete breakdown in the body's absorption assembly line.
So, you've got this chaos. How do you navigate it? Well, we have a master compass, and that compass is the D-Xylose test. This is the critical first step. It lets us figure out if we're dealing with a problem with the intestinal wall itself, or if it's a problem with the pancreatic juice, the enzymes that do all the heavy lifting for digestion.
Okay, let's look at the enemy dossiers. These are our main suspects. First up, celiac disease. Think of it as an all-out war on gluten, led by IgA antibodies. Then there's Whipple's. That's a full-on bacterial invasion. We've also got SIBO, small intestinal bacterial overgrowth, which is basically a bacterial hijacking of your upper gut. And pancreatic insufficiency? That's just a straight-up failure of the juice factory.
Okay, before we go any deeper, we need to pause. It's really important you understand. This is for educational use only. We're focused on helping you prep for international medical exams. This is not medical advice. For any clinical decisions, you must consult official guidelines.
All right, let's put this into practice. So, a patient walks in with those classic signs of malabsorption. The foul-smelling, oily stools. Your only first question should be, where is the failure point? So is it the pancreas just not making the enzymes it's supposed to? Or is the intestinal wall itself getting totally destroyed, maybe by something like celiac disease? Now, I know the temptation is to jump straight to a biopsy, right? But hold on, is that really the most efficient path? Absolutely not. And this is exactly where our compass, the D-Xylose test, comes into play.
Okay, so to really get this, you have to understand what D-Xylose actually is. It's just a simple sugar, a monosaccharide. But here's its superpower, and this is the whole game. To get absorbed, all it needs is an intact mucosal wall. It completely, and I mean completely, bypasses any need for pancreatic enzymes. This little fact is the key that unlocks the entire diagnostic puzzle.
So, here it is, the logic gate. If you give a patient D-Xylose and their levels come back normal, what does that tell you? It tells you the intestinal wall is working just fine. The problem has to be the pancreatic juice. Simple. But what if the D-Xylose level is low? Well, now you know the wall is damaged. Your differential immediately narrows to things like celiac disease. But, and this is a big but, there's a trap.
And this right here brings us to a classic super high-yield board exam trap. You see that low D-Xylose result, and your brain immediately screams, celiac. But wait a second. You've got to be smarter than that. There's another possibility hiding in the code. Here's the glitch in the matrix. Both celiac disease and SIBO can give you that exact same low D-Xylose result. And you have to ask why, right? Well, in SIBO, those overgrown bacteria in the small intestine, they are literally eating the D-Xylose sugar before your body even gets a chance to absorb it. So the wall could be perfectly fine, but the test result looks exactly like a damaged wall. It's a perfect mimic.
So how do you figure out what's really going on without sticking a scope down there? Easy. You execute the SIBO Shunt protocol. It's this beautiful, elegant three-step maneuver. Step 1. You give a course of antibiotics, something like rifaximin, to just wipe out that bacterial overgrowth. Step 2. You simply repeat the D-Xylose test. And Step 3. You analyze the new result.
And that second result tells you everything. If the D-Xylose level magically normalizes after the antibiotics, bam, you've found your culprit. It was SIBO the whole time. The bacteria were the problem, not the wall. But if that level remains low, even after the antibiotics, well, now you know for sure that the wall's architecture itself is genuinely damaged, and your diagnosis is pointing straight at celiac or sprue.
And hey, while we're on the topic, let's drop in a few more super high-yield clues for your exams. For Whipple's disease, you gotta know the classic triad: diarrhea, joint pain, and dementia. And the absolute giveaway on biopsy? Those periodic acid Schiff or PAS positive pink macrophages. Can't miss them. And for celiac, be on the lookout for a key skin sign, that super itchy rash called Dermatitis herpetiformis.
Okay, it is time to lock this logic into your neural matrix. We are going to run a rapid-fire drill. I want these connections sealed tight. Are you ready?
Low D-Xylose?
Think mucosal damage or SIBO.
Normal D-Xylose. Wall is okay. The problem is the pancreas. Pancreatic insufficiency.
Celiac antibody. IgA tissue transglutaminase, TTG.
Whipple biopsy? PAS positive macrophages. Lock it in.
Okay, let's bring it all home. This right here is your absorption refinery matrix. Look at it. Celiac and SIBO, they both kick off with a low D-Xylose. But the key difference? Only SIBO normalizes after antibiotics. And see pancreatic insufficiency over there? It's standing all alone with a normal result. This table, this is your entire logic flow all in one place, sealed and ready for instant recall.
All right, you have now mastered the core logic of the absorption refinery. From this point forward, you can confidently navigate the differential diagnosis of malabsorption.
Mission accomplished. The absorption refinery is officially secured. You now own the critical role of the D-Xylose test and the elegant logic of the SIBO shunt.
But listen, our work isn't done. The journey doesn't end here. Some of the GI tract's most dangerous territory lies ahead in the vascular and motility sectors. So, your next mission briefing is G2.3, Vascular and Motility Shunts. We'll see you on the front lines.